Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. As always, this is your chance to get your questions answered. Today is July 28, 2022, and we have a special guest with us today. This is Patrick Combs. He's the interim CEO of the Chicago Cook Workforce Partnership. And some of you may have seen an announcement we did this week about some new things that are happening in this space. And the Chicago Cook Workforce Partnership has been a really critical partner throughout our whole COVID response, and we're going to continue to be working together. So can you just introduce yourself, just a little bit about your organization, so if folks have questions they can put it in, and then we'll jump into all of our regular updates.
Absolutely. And Dr. Arwady, thank you so much for having me this morning. So as the doctor mentioned, my name is Patrick Combs. I'm the interim CEO with the Chicago Cook Workforce Partnership. We administer the workforce development system for all of the city of Chicago and Cook County as well. And we've been a proud partner of CDPH throughout this kind of pandemic fight, started as the contact tracing response corps and has evolved from there.
Yep, perfect. So we know you all have questions about monkeypox. We know you are still sending questions about COVID, and we wanted to really update you about what's happening with the partnership. So as always, we're going to start off with our dashboards, then we'll go through some presentations and then have time for your questions. You can put your questions directly into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. So we'll start off with COVID dashboard, chi.gov/COVID-. And if you pull it up, you see a mix of red and green here. We continue to be at a high level for COVID here in Chicago and Cook County. You can see we're averaging about 800 cases every day being diagnosed formally, in addition to the many more that are being diagnosed through home testing. You can see that's flat from a week ago. Hospitalizations also are actually down a little bit. We've not seen, even though we continue to see a lot of cases, we've not seen big increases in hospitalization, which is good. Our deaths, we're still averaging well under 1 death per day. That has been flat really since we came down from that initial Omicron surge. We're doing around 3,000 vaccinations a day, and both our emergency department visits and our hospital beds in use are approximately similar to where they've been. So no major changes in the COVID front. Still seeing a lot of cases. Encourage you to wear that mask indoors and test and, assume it is COVID until proven otherwise. I also just wanted to highlight, if you go to chicago.gov/monkeypox, you're going to get to our site here that has all of the information about what's happening with monkeypox in Chicago. We're going to be updating this site to have some more Chicago statistics on it. You can see here a list of organizations, which was a question that we got, healthcare providers, that are the providers that have been receiving vaccine. But I want to highlight that no matter where you are diagnosed with monkeypox, if you are, we can get your contacts vaccinated quickly, and that's our top strategy. So I'm going to go ahead and move into the slide update here. And we will kick it off with monkeypox because that's been most of our questions. So in our global outbreak, you can see in orange here the countries that have not historically reported monkeypox. And then in blue in West Africa, that's where we more traditionally see monkeypox that can be spread through animal contact, like with rodents. We're trying to call this MPV instead of monkeypox, just because this has nothing to do with contact with monkeys. It was just first detected initially in monkeys. But we are at pushing 20,000 confirmed cases in 76 countries. So this does continue to grow. In the U.S., nearly every state has now reported cases, and there have been about 3,600 cases. And as of yesterday, we were at 326 confirmed cases in Chicago. The overall risk to the general public of monkeypox remains low. And that includes the risk for men who have sex with men who are in monogamous relationships or not having new sexual partners. However, we want anybody who has a new or unexplained rash, regardless of your demographics, to see a healthcare provider, because most, but not all, of our cases in Chicago have been in gay, bisexual, or other men who have sex with men. That's consistent with what we've seen across the U.S. And in Europe. Our median age continues to be in the mid-30s. Our youngest case has been 22, and our oldest has been 66. Spread is primarily through skin-to-skin contact with the rash and the lesions. And you see some pictures on the right. The lesions can look like pimples or blisters initially. And the highest risk of spread is very clearly through sex and other intimate contacts, especially in tight-knit social networks. So if you have a new or explained rash, go to your doctor. Visit your healthcare provider. If you don't have one, you can give us a call at our regular number to get connected to care, and remind your provider if you have a concern for a new rash that they can test for monkeypox, and avoid sex or being intimate with anyone until you've been checked out. I want to remind you that testing is widely available. It is now plentiful. We can do 70,000 to 80,000 tests per week nationally, and now it's not just in public health, but it's also in the commercial labs. So Quest, LabCorp, the regular labs that most of our healthcare providers use can do the monkeypox testing. And the test is done by taking a swab of the lesion itself. It can be collected by any medical provider, and so please get tested, because knowing that you have this is the first step to making sure that people around you can be protected. There is also treatment available. It tends to be for higher risk people who are immunocompromised or getting more seriously ill. Still, right around 5% of our cases in Chicago have needed to be hospitalized for pain control for the most part, and because this can be very painful. And so those would be the settings where we're more often giving those medications. There is still a lot of paperwork involved because it's an investigational drug, but again, getting tested is the first step to, if you need it, getting treatment. And I just wanted to give you a sense of how much monkeypox testing in Chicago has been ramping up. This is the last 8 weeks, and you see that if you go back a couple of months ago, there were a small number of tests happening, and then if you go to last week and this current week, we're only partially through it, and we're already surpassing last week. So that's good. That's what we want to see. It's part of why the numbers are going up, because testing is getting better, and just want to see this continue to grow. Also, very good news, and this is what we've been getting the most questions about, is that the monkeypox vaccine supply in Chicago is increasing. Just to for those who may not have been following this closely, there is an FDA-approved effective vaccine against monkeypox. It's called Jynneos. It is designed to help protect individuals who have been exposed to someone with monkeypox. So because this is usually a rare disease, we'll see 0 cases, 1 case, 2 cases a year in the US, typically from people who have traveled to parts of the world where it's endemic. There were not a lot of vaccines available in what's called the Strategic National Stockpile. We don't have vaccine of this routinely at the health department, at your doctor's office, at a pharmacy. So the US has been distributing the relatively small amount of vaccine that was on hand and has been working to acquire more. So in the first weeks of the monkeypox outbreak here, Chicago received and distributed about 5,000 vaccine doses, which was actually a lot for a city, but nowhere near meeting the need. We estimate there's about 120,000 men who have sex with men in Cook County alone, and then also we would want to be vaccinating household contacts and others. And so I'm pleased to report that, as expected, 15,000 additional doses arrived from the federal government in Chicago over the weekend. Our team was in over the weekend, right away started packaging up and distributed, and we've been distributing every day, thousands just over the last few days. Our goal is to get these out quickly. There's more good news that additional federal vaccine doses are expected really over the next 1 to 2 weeks. There are more than 800,000 that are going to be distributed nationally, and they're looking at our numbers right now, and I expect a federal announcement with the state and specific to Chicago allocation numbers probably today or tomorrow. So the U.S. has also ordered even more vaccine, 2.5 million more doses, but those need to, that's been placed internationally. I don't expect that for probably a few months, just the way the whole world is looking for a lot more of vaccine. I also wanted to thank the state. Illinois Department of Public Health has redirected some of the federal vaccine supply that was received for the state to Chicago, just given that the epicenter of the outbreak has been here. And again, we are doing this based on the science, wanting to make sure that this is getting to the highest risk individuals first. As vaccine supply increases, it will be more widely available. You can see, just like testing, as we've been getting more doses, our monkeypox vaccines administered are also increasing really quickly. This is this ring vaccination strategy, which I've talked about, but the top priority is to vaccinate all contacts of cases. So on the left there, you can see if we have someone infected with monkeypox, the goal is to, as quickly as possible, after they've been diagnosed, vaccinate everybody who has been in close contact with them, especially any intimate partners. And then, ideally, if you do that successfully, their contacts, you're able to break that chain and you don't see further transmission. If one of their contacts goes on to develop MPV, we then will vaccinate their contacts and so on. The challenge is that, especially when we're talking about diseases that can be spread more through intimate or sexual contact, and skin-to-skin contact, there can be close contact where sometimes people don't know the contact information for all of their close partners. And so in addition to first and foremost using this ring vaccination strategy, right now, given the limited vaccine, we've got two categories of folks eligible for MPV vaccine in Chicago. So first, as I just said, close physical contact with someone or an intimate partner who was diagnosed with MPV. No restrictions. We will get you 2 doses of the vaccine, no matter where you get tested. That's top priority. And then secondly, recognizing that there are individuals at higher risk who perhaps they're in settings where they're having more intimate contact, but not necessarily having contact information for all of their contacts. Those are the settings where we're working to get vaccine out. So the second group that is currently eligible are gay, bisexual, or other cis or trans men who have sex with men who also have an additional risk factor. And those risk factors are having had intimate or sexual contact with other men or in a social or sexual venue, giving or receiving money or other goods in exchange for sex, or having intimate or sexual contact with multiple or anonymous partners. And again, that's because that ring vaccination strategy doesn't always work when you have a lot of close contact between individuals where we can't always identify. So we've been pushing vaccine out quickly. I want to thank the many, many clinical partners, the businesses, and the LGBTQ advocates who have been helping us with messaging, helping us distribute, and this is only going to keep ramping up. So again, just to underscore, the MPV vaccine is not recommended for the general public right now. It is also not recommended for same-gender loving men who don't have other risk factors. As supply increases, I expect that to evolve and we'll be able to open it up to more people. But this is the main approach. We also are prioritizing first doses of this Jynneos vaccine. So remember, our top goal right now is outbreak control. So we made a decision that anyone who is a known contact of an MPV case is going to continue to get those 2 doses. Being fully vaccinated with Jynneos means getting a second dose at least 28 days after the first dose. In addition, folks who are immunocompromised will do those 2 doses. But for everybody else, we are really prioritizing getting more first doses out, because otherwise we got 15,000 doses, we'd have to hold back half of those doses to give second doses. And just knowing with market days, knowing summer festivals, knowing summer travel, we feel strongly that it's more important to get more people that first dose. The biggest increase in protection is after the first dose. But even after that first dose, it takes about 2 weeks for those antibodies to be present. So we need people to be more careful with knowing contact information for anyone who you're in touch with. If you've got rash, get tested, stay home until otherwise. And we know that delaying the second dose doesn't affect the immune response. And that's the same approach others are taking. So just to finish up monkeypox, I want to make sure we're clear. I think I have monkeypox. What should I do? Isolate, separate from others, skip some gatherings and nights out. Don't share your personal items until you know what it is. Call your doctor. Remind your doctor that MPV is in the community and get tested. Let your healthcare provider know about this. Ask for a test. Our primary care providers all over this city are on this. We've been doing a lot of education and know that although most cases have been in gay, bisexual, and other men who have sex with men, they haven't all been. And so if you are developing symptoms, just go and get tested, okay? Thank you. Let's do a quick COVID update, and then we'll move into the last piece. So again, this continues to be a major pandemic. We show no signs of this ebbing or this becoming something that we're not going to see anymore, where we've had more than 570 million cases around the world, more than 6 million deaths, 12 billion vaccination doses administered. And you can see in dark purple there, really Europe, Australia, New Zealand continue, and parts of Asia continue to have the highest number of cases. So especially if you're traveling to those parts of the world, use some extra caution, masks, etc. If we look at the U.S., again, the darker areas are where we're seeing more cases right now. You can see nationally, we're averaging about 39 cases per 100,000 being diagnosed formally. Illinois is a little above that. Chicago is actually below that, but there is still a lot of COVID. And in fact, 80% of U.S. counties are at either a high or a medium COVID community level right now. Our risk here is high. Just as a reminder, you get to that high level as defined by CDC if you have more than 200 cases per 100,000, which both the city and the county do. And then if you're seeing people get hospitalized, the city is actually quite a bit below the threshold for hospital admissions, but Cook County as a whole in the region is above it. And so we remain at a high risk level. You know, I take the L every day. People are doing a pretty good job of masking. I would encourage you to continue to do that, especially indoors, especially where you're around people that, again, you can't contact, you don't know who they are, you don't know what their risk factors are. Everything continues to be Omicron, basically, and almost all BA.4/5. That's what that green is there. So almost 95% of our cases in Chicago and across the Midwest are this most infectious yet Omicron subvariant, and that's why we're seeing more of these breakthrough infections. That's also true across the U.S. It's mostly this BA.4/5. A lot of you were asking about what's happening with BA.2.75, which is sort of the newest variant on the horizon. There are some additional mutations in this. We've seen some spread globally, but actually pretty low numbers outside of India. We think if there are folks who didn't see, in parts of the world that didn't see a lot of the prior BA.1 infection, maybe there's some more risk. But just to put this in some context, there have been 250 cases sequenced with this variant, 13 in the US, 3 of those in Illinois. It is 0.01% at this point, and it's not at this point clearly showing that it's going to be another major wave, but we are keeping our eye on it. We do a good job of testing and looking for it here, which is one of the reasons why we may find it. But get up to date with your vaccines. Remember, if you catch COVID, you have to stay home for 5 days. Full stop. If you are feeling better, you can be out and about after that, but you've got to mask for days 6 through 10. And just a reminder, if you haven't gotten a booster yet, unless you just started to get vaccinated in 2022, if you are over the age of 5, you should have already had a booster shot. And if you're over 50, you should have had 2. So come up to date if you're not. We're seeing a good increase, although the numbers are still very low compared to where I'd like them to be. About 8% of Chicagoans under 5 have gotten that first dose of COVID vaccine. This Saturday, we're at Wilbur Wright and Richard J. Daley College. We've got adult, pediatric vaccines and boosters free. You can register. You can also walk in. And we continue to do our at-home vaccination efforts. So if you need a vaccine or a booster, any questions, check out the website or call 312-746-4835. Similarly, if you've got questions about monkeypox, chicago.gov/monkeypox, or you can call that same number. I also want to highlight CDPH operates an HIV STI resource hub. So especially if people are having questions that may be related to LGBTQ questions or how this may relate to other sexually transmitted infections, folks at this number can definitely answer your questions in a really affirming way, I think. And I encourage anyone to reach out who continues to have questions. All right, I'm going to turn it over for this last part of the presentation to Patrick Combs. If you missed at the beginning, he is the interim CEO of the Chicago Cook Workforce Partnership. And where you've seen me show all through COVID, lots of pictures of the on-the-ground folks really doing a lot of the door-to-door, the call answering. This has been really organized through Chicago Cook Workforce Partnership. And I'm going to hand it over to Patrick to talk a little bit about that, and then we'll come back and get all your questions.
Dr. Arwady, thank you so much, and thank you for that great information. As the father of a 4-year-old who just got his first vaccination, it is exciting that that's a possibility.
Love it.
But yeah, so I'm Patrick Combs. I'm here to talk about the Chicago COVID-19 Community Response Corps. So this is a program that we've been operating in partnership with CDPH since summer of 2020. So through a competitive procurement, we were chosen to be the lead coordinating organization to lead up this work. It was the beginning of COVID. Nobody really knew what was going on, and what we knew is we needed to do contact tracing. As we've learned through this pandemic, it's important to know who's impacted and who they know has been impacted. And I have to say that I've been doing this work for a long time. This is probably the most impactful program I've ever been a part of, because not only has it been a workforce development success, which is kind of our bread and butter, but it's been a public health success and an economic development success story. Thanks to Mayor Lightfoot's leadership of saying, I want this work done in the community by people living in the community. We've been able to partner with 31 different community-based organizations to do this work. So as people got a call, reached out, called one of these numbers that you mentioned, they weren't calling somebody from far away. They were talking to somebody who might be even on their block, but within a couple miles of them. So again, we operate the workforce development system for the city and the county. We touch about 140,000 people per year who are looking for work, and about 1,000 businesses who are looking for talent. And we've been doing this this is our 10th anniversary this year. We do it through a network of about 90 delegate organizations who really, again, help us get into community and make sure we're making the impact that needs to be made. So going into this role in the Community Response Corps, we are not public health experts, we are workforce experts. But as we've learned through the pandemic, it takes a village and it takes having a great team. So we're able to partner with really strong organizations, UIC, University of Illinois Chicago, their School of Public Health, who did a lot of support for the CBOs in our network. Malcolm X College, who trained all of our core members again and again, and really built up these core members to become public health experts. Sinai Urban Health and SUHI, who provided ongoing support to the core members, and really, as things changed on a weekly basis, we were making sure that new information was getting into their hands. And then NORC and ORC at the University of Chicago helped with the resource hub. So, as I mentioned, we partner with 31 CBOs to do this work, and this is really why this was so successful, and this is why this is a success on multiple levels. The mayor, when they put this together, and through your leadership, Dr. Arwady, said, the way this is going to be the biggest success is if we partner with people in communities that are hardest hit. So we looked at this economic hardship map that was put together by the city and really focused on these communities where there was the biggest economic and health impact of the pandemic, and tried as best as we could to partner with organizations in these communities. Again, so neighbors were talking to neighbors, community residents were talking to other people in their community. So these are the 31 CBOs that we chose throughout the process, and it has been amazing to work with these organizations. Some are public health, some are workforce facing, and some are just people who are in their community and said, we want to do what we can to support our community through this pandemic. Again, it's going back in the Wayback Machine to 2020. People didn't know what they wanted to do, they just knew they wanted to help. And we've been able to build out this core, and it's been an amazing experience working with these individuals. And as you can see, a lot of them are in the communities that have been hardest hit by the pandemic. And so the economic development success story of all this is a lot of the money that's been going into this is going directly into wages provided to the core members. And so during the height of the pandemic, when things were shut down, when unemployment was still 20%, millions of dollars through wages were going directly into the communities that had the hardest impact. And it was just a really amazing success. So we started off doing contact tracing. But as the pandemic changed, we changed with it, and we would get calls on a almost morning-to-morning basis from CDPH saying, okay, so here's what we're going to do today. But it's because as the pandemic evolved, as the needs of our community evolved, we evolved with it. So we started with just doing contact tracing, and then it evolved and expanded to doing vaccination pod supports. If you got your vaccine at the United Center, you probably talked to somebody in the Corps who helped set that up for you. If you went to one of the early vaccination pods at the different community colleges, you probably talked to somebody in the Corps who helped you out that day. The Promotorios de Salud, the community health work, so that was really our first foray into doing that health ambassador work, going door to door, talking to people, reaching the people who we didn't get through the first wave of outreach, to really try to get down there and get those vaccination numbers up. The COVID hotline, and then the canvassing and community outreach. All layered into this is the workforce development aspect of it, the earn and learn part of it, we saw this as an opportunity to take what we thought would be jobs that would not last forever, and really try to build up individuals and create this new public health workforce, which we've been able to do. So people who were either unemployed, underemployed, most have never worked in health, are now have multiple credentials, years of experience, and are now a fully trained workforce for the city's needs.
We've hired some directly at the Chicago Department of Public Health.
We've hired some too. It's been really exciting. And again, it's taking this opportunity to do this giant transitional jobs program to build people up and to build this workforce. So as I mentioned, core members have received a lot of training, and big shout out to Malcolm X College for their support in this. They created new pathways, they created new programs just to support the core. The City of Chicago Hotline, formerly the Resource Coordination Hub. So this is, I think we've answered over 200,000 inbound calls and placed over 80,000 outbound calls. So again, you know, if you're reaching out, if you have questions about COVID and now kind of questions about public health, and you don't know who to talk to, you can call these numbers. Call 312-746-4835, and you're going to talk to somebody in your community. You're going to talk to somebody living in Chicago who is feeling, you know, the same weather you're feeling, who's going through the same experiences you're feeling, to help you answer your questions. And then career work. So we hosted a career fair at Malcolm X College for members going through the first part of the response corps. We had dozens of employers. Over 100 people have already been hired through that hiring event. You were nice enough to come and speak. We gave some awards, and it was just a really exciting way to highlight the success of the Corps and just promote these wonderful people who have been trained, who have been doing great work, and who are now moving on to the next steps in their life. And I think with that, we are moving on to questions.
All right, perfect. Thank you, Patrick. So go ahead and put your questions in the chat. Let me just get switched over so I can see what's coming in. Okay, so folks have questions for you. So let's start off with a little bit for you. We'll kind of go back and forth between COVID and monkeypox and some of this. So people are asking, how much money do people in the Corps make?
Sure. So in the first year of the Corps, and it's ongoing, Corps members make $20 per hour and supervisors make $24 per hour.
All right, perfect. And then let me just, a couple things here. So what's next? You know, I know that we put something out yesterday. Talk a little bit about, and we can both talk about this together as we sort of think about this next phase. Let me add just a little bit more context, and then we'll jump into, I see a number of these, like, what's next? I want to do this. How do I join? So this was a very unusual approach, especially to contact tracing. If you think about those very early days, my inbox was getting filled with call centers or universities, and that's what most people did around the country because that was a very fast way to solve a problem. But we really wanted to create a workforce and have this be an economic engine as much as we could for the parts of Chicago where it was most needed. And you know, it has been a huge challenge, but unbelievably positive. And you know, every person who has worked on this program, from the CBOs to the lead partners to the Chicago Cook Workforce Partnership, has just been willing to be adaptable because everything from the funding to the direction that we're going has been changing. And so, you know, I'm happy to share that we did not want this to just end, right? And so just yesterday, you know, we again did a RFP competitive process and are awarding another $24 million to the Chicago Cook Workforce Partnership to be able to mobilize and sustain a smaller version of the Chicago Community Health Response Corps team. And I'll let you kind of chime in on that. But this is around this idea that we've seen such success from this. We've got these massive public health problems that are always going on, right? Whether it's diabetes, the chronic things, et cetera, et cetera. And we need a workforce that can very quickly pivot. So that can be handling the COVID issues and now the monkeypox issues and now whatever's next. And continue to really take this model and have it be something that we grow and hopefully sustain if we can continue to get sustained public health funding at the federal level. So do you just want to chime in some more details? Because various people have questions.
Yeah, absolutely. And so, yeah, as Dr. Arwady mentioned, we got awarded yesterday a new award to the core will be shrunken down. We're going to go from 30 CBOs to probably about 20 CBOs that we're partnering with, but we're expanding what we're doing because the first round was solely focused on COVID, because that's what we were responding to at the time. But we realized that through the many pivots, that having this adaptable, flexible model, we're able to pivot and we're able to respond to more things. So now with monkeypox coming up, if people have questions about that, they can call and they can work with the core. We can then go to different events, different venues, specifically talk about these things. And whatever comes next, we can talk about how, violence is a determinant of public health and poverty is a determinant of public health. And what can we do as a community to support those things? So this new effort will go to that kind of expanded reach. And just as we just responded to a new RFP, we'll be putting a new RFP out soon for a new suite of CBOs that we're going to be partnering with. To, again, move this work forward. Once that's in place, we're also going to post or activate a website where if you're interested in being a core member, you'll be able to go, you'll be able to put your information in there, and then we'll contact you once new hiring begins. When we first launched that in July 2020, we crashed the website. It was about 30,000 people overnight. The labor market's a little bit different right now, but it's still a great opportunity to give back to your community, learn new skills, and get paid while you do it.
Yep, absolutely. Wonderful. And this is, just to be clear, it's part of the Chicago Recovery Plan. So this has been created, with federal funding to support recovery from social, economic, and health impacts of the pandemic. But we want this to be broader. So I think we'll take one more for you and then get in here. So do organizations applying to this group, I think the eventual RFP, do they have to be working on health?
No, absolutely not. As we saw from the first round, some were solely focused on workforce development, some were health focused, and some were just strong community-based organizations that knew how to outreach to their community. So you do not have to have a background in health or public health to respond to this RFP.
All right, good. So quite a lot of COVID and monkeypox questions here. So I see Connor Nichols on Facebook saying monkeypox looks exactly like autoimmune blistering disease from Pfizer documents that were released. So I want to emphasize that we are seeing monkeypox. What it really looks like, if you're a doctor, is it looks like a pox, like you would have seen in the old days from smallpox. We don't have smallpox anymore, so it's not something that doctors necessarily will automatically say that is for sure a pox. And so we've been using language to say it can look like a pimple, it can look like a blister. I want to emphasize that we don't have any suggestion at all that this is autoimmune at this point. Certainly when you are responding, when you are infected with a virus, and it is a known virus that has been known for decades and decades, you will have a different presentation, partly based on your own immune system. We see that in COVID. But really, whether you just have a few new, they look like pimples or blisters, on your hands or on your face, or what we are seeing, many more people have lesions in the genital area, especially if it's related to sexual contact. Go and get checked, because that's the way to get diagnosed. Nobody can say whether or not you have monkeypox based on what it looks like. All right, let's take a couple of quick COVID ones, of which there are a lot. Let's take Yvonne Ramirez's question first on Facebook. At what point after an infection, a COVID infection, am I no longer contagious? I'm having trouble determining. My symptoms have lightened. I'm 2 weeks out, but my allergies are usually bad this time of year. Okay, and we've got a number of questions that are sort of in this range where people are having COVID sometimes for the first time. So generally, at the population level, we have the most concern for people being contagious in the first 5 days after their symptoms start. That is why you have to stay home for 5 days. We have the next level of concern for days 6 through 10, which is why if you're feeling fine at that point, we say you can be out and about, but you need to be wearing a mask. The risk at the population level drops significantly after day 10, and that would even include for some people who have lingering symptoms. But I hear you that you're 2 weeks out at this point, and you say, you know, I'm still having some symptoms. Is this allergies? Is this not? Number one, I always never ever am I going to give an answer that is different than if you have concerns about your own personal health. Always my recommendation is going to be to talk to your doctor, your health care provider who knows your whole history. I don't want people thinking, oh, I've had, you know, this terrible chest pain going on for 4 weeks and it's all related to COVID. Like, go see your doctor if something doesn't seem right. But if you're mostly feeling well, especially if what is still kind of lingering is a cough or a little bit of cough tends to be the last thing to go away after any virus, it is unlikely that you are still spreading disease, you know, out 2 weeks later. Some people have been using home testing to add an additional level of comfort to that. I want to be very clear that if you go and get a formal test, a PCR test, that can stay positive for weeks sometimes after you've had COVID because it's so sensitive. It can pick up even dead virus, little amounts of virus. So I don't have, you know, you don't need to show a negative test to return to work, for example. But those at-home tests can give you another level of support. And if you are, you know, at 14 days out, and you're still like, oh, I don't know, I'm still not feeling that well. You know, if possible, when you're not feeling well, limit your interactions, definitely wear the mask, but also you can take a COVID test. And if it is negative, that's another piece of information that suggests you're very unlikely to be contagious at that point. So, you know, no test is 100%, just like no vaccine is 100%, but those tests are pretty good. I encourage people, they're what I use myself with my family. Okay, let's take another COVID one, and then maybe we'll go back and forth here. And actually, similar to this, Alexandria Dion on Facebook is saying, if I had COVID a few weeks ago, but I'm still positive, how do I know if it's a new infection or lingering from my old one, since this variant can cause reinfection sooner? Am I safe to be around people? So the two questions I would ask is, what kind of test is this? If it is a PCR test, one that you get at a doctor's office, one that you get at a testing center, that is not telling me anything except that you had COVID not that long ago. If it is a home test, we can't 100% know. But if it's been, I mean, I don't know, a few weeks ago, it would be unlikely that you would still be testing positive in a way that you would be contagious sort of at that point. I'm going to tell you that if you are in doubt, please wear a mask, and please don't have close contact with folks who are immunocompromised, right? I hope that goes without saying, but that really would be my recommendation. The question of, is this a reoccurrence? Is this a new version of the variant? Let's talk about that for a second, because I see a number of people asking about that. So first of all, yes, especially with BA.4/5, we are seeing more examples of another infection, even people who had an original version of Omicron. We're not seeing a lot, just to be honest, at all, of people like, I have COVID and I got it 2 weeks later. Like, that's not really what we're seeing. If you look at that graph that I showed you with all of that green increasing, frankly, if you got COVID in the last few weeks, almost certainly it was BA.4/5 to start with anyway. But more of where we're seeing reinfection are people who maybe had Omicron back in January, February, some of those earlier versions. What's different is that before Omicron, before BA.4/5, we weren't seeing different versions of the same variant. We weren't seeing reinfections with that. So it was like if you had Delta, you were pretty good until we maybe saw another variant. What we've seen with Omicron in this most contagious version yet is that even subvariants you can get a reinfection with. But you're very unlikely to get seriously ill, by the way, if you've recently had an infection, assuming you're up to date with all of your vaccines. So what I can say is, if it's a PCR test, disregard it. If it's a home test, be careful. You can't know on an individual level for sure. Most people, though, are not getting reinfected again right away. Most people where we're seeing reinfections, it's people who were, who are months out in most cases. And I can bring some more details of that data if you're interested next time. All right, let's take another partnership question here. What have you learned from working with the range of different community-based organizations? It sounds like there were a lot of different types of organizations.
Yeah, so I mean, we've learned that, again, not every organization is built the same. And so they all have different strengths and weaknesses. And so as a provider, we have to work with them to make sure they're getting what they need to succeed and what their core needs to succeed. What we have learned, though, is that they are all driven by helping their communities and by impacting the people that they work with day in, day out. And so we at first would feel bad when we'd have to call them up and say, remember what we told you we're going to do yesterday? We're doing something totally new today. Or remember last week when we said we're only doing this? Now we need your team to totally change. But then we learned is they were totally on board because all they wanted to do was support their communities. So what we learned is that although they all look different, they all have that same underlying drive of service and drive for supporting their community.
Great. Couple of questions about new vaccine. Why don't we take a couple of those? So again, this is about COVID. Face State on Facebook says, "Hi, great article on you leading architecture tours." Yeah, WGN did a piece on that. I do that for fun. That's just a fun thing. But she says, now a COVID question: when do you think the new vaccine will be available? So, in case not everybody has been following as closely as Faye, we are anticipating a new updated vaccine in the fall. All the vaccines we've been using to date, all the boosters have been the original version of the COVID vaccine, created to help protect against the original version of COVID. The updated vaccine that will be coming has been updated to better protect against variants. And the reason, I don't know for sure when it is going to be here. I would put my money on October or possibly November. Hopefully October. And the reason it's not until October is there was a decision, which I agree with, to wait to get the BA.4/5 protection in. The studies were sort of done and they were about ready to go with starting to manufacture this updated vaccine, which would have had it available more in sort of an August-September timeframe. But then BA.4/5 was starting to emerge. And so there was a decision made to hold back, to make the vaccine that can also cover 4/5, just given that we've seen additional mutations. So I think that was the right decision, but it means that there will not be an updated vaccine. It takes at least 3 months, right, to sort of decide to produce the vaccine, get all of the studies and the manufacturing and the distribution done. So I'm anticipating it'll be in that time frame. We'll certainly keep you updated, but that will be a federal announcement when it is available. And then Tiffany Hagstrom on Facebook is similarly asking, do we know an efficacy? Do we have an efficacy we are expecting with the variant-specific boosters? Really good question. So, as you know, the current vaccines and boosters have continued to be incredibly protective against severe illness, hospitalizations and deaths, thank goodness. But we've seen so much more of these breakthrough infections. We don't yet have sort of official efficacy numbers. There will be efficacy data released, but right now, again, is the process of getting these vaccines, these updated vaccines, especially with the BA.4/5 in there. I am confident that they will have more protection against the breakthroughs. And my guess is we will be recommending this for certainly all adults. We'll see what happens around kids. But as opposed to continuing to boost with the vaccine that exists, I think the new and updated vaccine should give us a really improved protection, not just against severe illness, but against all of these variants. And we'll have more specific numbers as we get closer to the date and all of the studies are getting done. Good question. All right, okay. Let me take one more monkeypox and then we'll circle back one more time. How are we doing? Oh, we're still a little okay on time. Matilda Fuentes de Guerra on Facebook. Why don't you give monkeypox vaccines to those who want to get them? Good question, Matilda. So the reason I was sharing some of those numbers about monkeypox vaccine is that different than COVID vaccine, we don't have a lot of actual vaccines yet. Like, it is literally a supply and demand issue. So I'll remind you that at the very beginning of COVID vaccination, boy, did the entire world want to get a COVID vaccine, right? Yep. And we had to do a lot of work to prioritize healthcare workers, the oldest Chicagoans at highest risk, And then the people working in the jobs where you couldn't distance and the communities that were getting hardest hit, that was a hard time for Chicago because it meant, saying yes to those most vulnerable groups by definition means saying no, and you have to wait a little bit to the groups that are not at the highest risk, even though we know you want vaccine. So I wish this were like the COVID vaccine and we had plenty of it and we could just say, go get a monkeypox vaccine if you have a concern. But because the numbers have been low, that's why we've been, just like we did at the beginning of COVID, we've been having to prioritize our vaccines to do the most we can to stop the spread. And so just to remind you, the number one priority for monkeypox vaccines in Chicago, across the US, is anyone who is a close contact, especially an intimate partner, of someone diagnosed with monkeypox. So that's why it's important for you or anybody, go get diagnosed, because no matter where you get diagnosed, if you've got a positive test, we will work quickly. We use our case investigation and contact tracing. We can protect your privacy. We have ways to do this. We can reach out to your close contacts, anyone who you've had close contact with, in the 14 days or so prior, and get them vaccinated. Because if you can get people vaccinated, you can actually, in most cases, prevent them from getting monkeypox, okay? So that's the top priority. And then the second priority, again, are the individuals in Chicago who may have had may have had exposures that put them at higher risk for monkeypox, but perhaps those are anonymous or were not able to do the traditional case investigation or contact tracing. People have been traveling, whatever the case may be. Those are individuals, and again, that's why I laid out the guidelines. That's who we're prioritizing. When we only had 5,000 vaccines, and we knew there were 120,000 men who have sex with men, and knowing that there are contacts and others who may not be men who have sex with men, that means the demand far outstrips the supply. Getting 15,000 in over this last week helped. We are pushing out even more vaccine to even more clinical partners, doing more outreach events, obviously in advance of some of the large events in the summer that bring people. We've been pushing to get that vaccine out, but it's not all vaccine. Some of this is about making sure people have the knowledge that they're talking about this, especially before close or intimate contact, and that if you've got a sore, get checked before you're doing any of that. Okay. Let me take one more monkeypox, actually.
Sure.
So can I get a couple things coming in here. Let me just hit them quickly, and then I'll hit them. Why aren't we calling monkeypox a sexually transmitted disease? Can I get monkeypox on the train or bus? And are you going to put numbers up on your website? All right. Are we going to put numbers on our website? Yes. Chicago.gov/monkeypox. So at least once a week we'll be putting them there. We're going to see kind of how things develop. We've been releasing information. We've got lots of calls sharing it. But yes, we've made a decision to start putting some numbers on the website. And I want to emphasize that we have seen cases in the majority of our Chicago community areas at this point. So sometimes people think, this is just on the north side, whatever. No, we are seeing cases on the north side, the west side, the south side. And once again, if you might have symptoms, please go get tested. Can I get the monkeypox on the train or the bus? It would be very, very, very unlikely, assuming that you're not kissing people for extended periods, for example, on the train or the bus. Yes, it is skin-to-skin contact. So, if in theory, if you had two people right up against each other and somebody had, a sore, an open sore, there is a theoretical possibility, but that is very low risk. We do not consider this high risk to the general public. 300 something cases is a lot of cases, but in a city of almost 3 million people, especially where you think about COVID, we are high risk at the general public for COVID and low risk still for monkeypox. People try to give each other distance anyway on the L or on the bus. And I'd say if you have a concern, don't get on a really crowded bus. That's good from a COVID perspective as well. Just to put this in some perspective, I know a lot of people with case investigation and contact tracing have gotten used to this idea that, did I spend 15 minutes within 6 feet of somebody without a mask? that can be pretty high risk for transmitting COVID. When we're talking monkeypox, we're talking like 3 hours of that level of sort of, the casual contact. So really, I don't have concern for people going out and about, being in grocery stores, being on the L. Almost everything we've seen has been this close or intimate contact or household contacts of known cases. And we've also been following healthcare workers, just to put a little more detail on that. So that is obviously a group that we can trace quite well, because if somebody tests positive for COVID, they have been in contact with the healthcare workers at that organization. And ideally, they're all wearing PPE, but sometimes they're not. And so we're able to kind of also look and see what are risk factors, where do we have that. We've had no cases diagnosed in healthcare workers to date in the city of Chicago. And that includes people taking swabs, interacting. We continue to monitor folks, but again, reassuring in terms of pretty different than what we would see with COVID. And then finally, why aren't we calling monkeypox a sexually transmitted disease? So the number one way monkeypox in this outbreak is being transmitted is through sex or intimate contact. However, the virus itself traditionally is actually spread through contact with animals. The prior outbreak in Illinois, there were some I think it was Ghanaian. There were some imported animals from West Africa. Those animals were in contact with prairie dogs in Illinois. The prairie dogs got infected, and then we had about 50 or so individuals across the Midwest who had contact with prairie dogs get infected. So that is the traditional way that infection happens. It is different for us to be seeing so much spread person to person. That has not been the typical way, and that's why we're having an outbreak. And so it is about skin to skin contact. When do you have a lot of skin to skin contact? When you have sex, right? And that is the highest risk activity. But it is possible to transmit through kissing, for example, if you have a lot of respiratory secretion exchange. It is possible, not common, but possible, if there were someone who had monkeypox and fluid from sores got onto bedding and someone else was touching that bedding, you could have transmission. So although the current outbreak, it is being transmitted primarily through sex, it's about contact with bodily fluids, not just sexual fluids, and it is transmitted through ways other than sex. So certainly our sexually transmitted infection clinics, including at the health department, are on high alert and looking for this. We are encouraging, if it is someone who is reporting some perhaps riskier sexual behavior, to not just test for monkeypox, right? To also test for the other sexually transmitted infections. But that's why. So I hope that helps explain it. All right, we are almost at time. Let's finish off. Again, if you joined late, Patrick Combs is the interim CEO at the Chicago Cook Workforce Partnership. And the Chicago Cook Workforce Partnership has been the lead coordinating organization with more than 30 community-based organizations, mostly across our west and south sides, that in turn hired hundreds of Chicagoans. Earn as you learn, and they have been the core of our on-the-ground response. So let's take this as a last question, because I like it. Someone's writing in, it's great to hear this work is continuing post-COVID, especially with still low vaccine uptake where I live. I always want to have more trusted messengers, more people in my community. How are core members going to be trained on different health-related topics if that's not their original area of training or expertise?
Oh, that's a great question. And we've learned this through the first iteration of the core and through learning about COVID. As the different variants came out, as Delta came out, we got a lot of questions. As vaccines came out, we first were trained people how to do contact tracing. So it was how to answer the phone, how to go through the script. All of a sudden it was, okay, how do we answer people's questions about vaccines? What does it mean? What are the risk factors? So that is why we partner with our public health partners. So SUHI, University of Illinois Chicago, Malcolm X, and of course CDPH. As these new topics come up, the core members go through intense training to learn about all these different issues. So when they go out in community, they're going out there with the latest information. The kind of information you're hearing here today is what they're being trained on. So when they go out there in community, they are as knowledgeable as possible about whatever the public health issue is at that time.
Yeah, and let me tell you, we get a lot of outreach. as people have come to see what an amazing job this group of folks have done, people are often reaching out to us saying, oh, can we train, your core on this issue or that issue? This is something that is going to be hopefully sort of bread and butter of the work that we do long term. And we have seen very clearly that with good training and repeat training, updating it every week, absolutely, especially for that first level of questions, having those trusted messengers in community is where we build this. The core is trained that if they are getting questions they do not know the answer to, they know how to escalate it, and the CDPH staff are able to fill that in. It helps us also, just like when I do Facebook here, seeing what questions people are asking every single day helps me a lot as we think about what messaging, where are we not as clear, how do we need to adjust. They are doing the same thing on the city scale, saying, here's what we're getting a lot of calls about. There's sort of a feedback loop where we work to change our messaging, get more information out, and it's been a really critical partnership. I'm going to end with a couple last COVID questions. Vanessa Lopez on Facebook says, what can be done about COVID brain fog? How do I know if that's what I'm experiencing or if something else is at play? How long could it last? Please go see your doctor, okay? That is just the answer. And that's the answer for anybody who's saying, something doesn't seem right. I think it could be related to COVID. We are still learning a lot about quote unquote long COVID, but please go see your doctor, okay? And then Ann Carbonetto on Facebook. I saved your question because it's long, and we are going to be addressing it in a lot more detail in the weeks to come. She's saying, I'm worried about what the next school year will look like. If masks are not required, they won't be worn by most. What if we're seeing COVID spread like wildfire? Are employees getting more sick leave? What's happening with childcare as people are out? If there's not remote learning, will people miss a lot of school? We can't afford that for learning loss. If you're not backing away from a 5-day isolation period, what's the plan for staffing and learning? So Anne, those are excellent questions, and we have been working really, really hard with not just Chicago Public Schools, but with the Archdiocese, with the independent schools, with our early childhood education settings, helping them really get their policies and plans in place with the school year coming. Remember that when we talk CPS, there is a very robust summer school program that has also been going on, and so it's been a really nice opportunity to make sure that we can use some approaches that have been shown to be safe and effective. So, for example, if you keep tuning in here, we're going to bring in some education partners, but you're going to hear more about a program called Test to Stay. Test to Stay means if your child is not up to date with the vaccine, still under CDC guidance, they would be asked to quarantine if they're a close contact. We know that leads to a lot of disrupted learning. We know that that is hard for parents who are trying to work from a child care perspective. And so we've had a number of pilots. CPS did some pilots even last spring. We've had some of the independent and Catholic schools doing this. We've been collecting data. And we've seen that even when kids are unvaccinated, we do often require masking then if you know there's been a case in a classroom. And there's some other things that we can do. But we actually say you can stay in school as long as you remain symptom-free and your testing at a couple different levels stays negative. Where we did that with some of the other school systems, we were saving thousands of in-person school days. And so you will be hearing much more about this. It's an example of as testing has become more available, as more people have had the opportunity to get vaccinated, continuing to adapt practices. So it's premature. I'm not going to be the one sharing, the details of CPS planning, but certainly CEO Martinez and I will be doing more together. And if you're not in CPS, your schools know that we are working with them too. And I don't have major concerns about the school year at this point. Will there be COVID? Yes. Will there be some COVID outbreaks? Yes. Do we have the tools to control those? Absolutely. If kids and staff are fully vaccinated, and that means including the boosters and getting the little ones vaccinated, it is the most important thing. It really is for decreasing the risk of spread, for decreasing the risk of worry and the serious outcomes. And added to that, where we need to use masks, you already saw CPS said we're not doing a mask requirement. CDPH is in support of that. We do not think there is a requirement at this point, but there are settings. If there's an outbreak in a classroom, if you've got major issues in a school, et cetera, where CDPH would be recommending a period of masking to get through that outbreak. And then obviously the big question is variants and what happens next. We have seen since early in COVID that being in school is actually not a significant risk factor for developing COVID. It's when people tend to let down their guard more. And we know that our schools are also some of the places that have had the most investments in terms of ventilation, in terms of some of the hygiene and sort of awareness. And we're never going to have a completely COVID-free environment unless there's some major breakthrough. But we've got to focus on keeping the risk of COVID low, but also doing everything we can, as you know, to keep up, to recover from learning loss and make sure that kids can be in school. So there will be much more coming, and we've made a commitment to not wait until the last minute before school is starting. You saw, for example, CPS put out some information about masks yesterday. There will be much more coming, and we'll do everything we can to explain that. So thanks for highlighting some of that. Know that there are answers coming to all of those questions. So with that, I think we're right at time. So thank you again.
Thank you.
Patrick Combs from the Chicago Cook Workforce Partnership. We are doing a ton of work in Chicago to think about what comes after COVID. Doesn't mean COVID's over, but in terms of that pandemic really upending our lives all the time, I remain really hopeful that that part actually is over. We get a new variant, there may be a time where we might need to reinstate an indoor mask requirement, or we might need to even reinstate a vaccination requirement for high-risk settings. But that time is not now, because the vaccines we have now are doing such a fantastic job at protecting against severe illness. It's not 100%, but it's pretty amazing. So if you're worried, everybody around you, get your vaccine, get your booster, get up to date. Take a test, stay home if you're not feeling well, but enjoy summer and the fact that when we can be outside, that significantly lowers the risk. So I want to wish you a happy Lollapalooza weekend. The Chicago Department of Public Health, like city agencies around the city, are on call and working to make this a successful and as safe as possible Lolla celebration. And with that, we will be back at our regular time next Tuesday, August 2, 11 a.m. Keep sending your questions in and watch both chicago.gov/COVID, but also chicago.gov/monkeypox if you want to see really every day there's additional updates coming in, and that's your best source to get the up-to-date information. Watch for hopefully some good news for even more vaccine coming to Chicago, and know that we have the apparatus in place to push this out just as quickly as even more is available. So thank you again. Thanks for your attention. We'll see you next week.